The thorax houses numerous structures, including the heart, lungs, nerves, blood vessels, bones, and muscles. Let's quickly discuss thoracic anatomy and physiology. The skeletal system protects vital structures and acts as attachment sites for muscles and ligaments. The pleura, a double membrane with visceral and parietal layers, encases the lungs. The visceral layer encapsulates the lungs, while the parietal pleura attaches to the chest wall. Between these layers is called potential space, and it holds a small amount of serous fluid, which creates surface tension, preventing layer separation. Remember that at rest, the lungs want to recoil and the chest wall wants to expand, but the negative intrapleural pressure prevents them from separating, allowing the chest wall and lung to couple and facilitate ventilation. Respiratory muscles such as the diaphragm and intercostals are also vital for efficient ventilation. As per Boyle's law, the respiratory muscles contract, increasing the intrathoracic volume and decreasing the pressure. This allows air to enter. During passive expiration, the muscles relax, the volume drops, and the pressure rises, allowing air to escape. However, during respiratory distress, one can engage the abdominal muscles to aid in active expiration. Before we continue, it's important to note that the intercostal muscles are located between each rib, and the neurovascular bundle, consisting of nerves and blood vessels, lies inferior to each rib. The pericardium, a double membranous sac, surrounds the heart and allows it to beat freely. The heart and major blood vessels, which are located centrally in the mediastinum, are subject to pressure changes within the thorax as blood moves from high to low pressure. This is particularly important for the vena cava, which has a pressure approaching 0 millimeters of mercury, making it more susceptible to pressure changes. Understanding this basic anatomy and physiology is essential for recognizing how chest injuries can impact these structures and their functions. Chest injuries can lead to various pathologies that often present with overlapping symptoms, making differential diagnosis extremely challenging. When assessing chest trauma, it's essential to consider the mechanism of injury, distinguishing between penetrating and blunt trauma, as well as the force and speed of impact. Additionally, understanding the patient's medical history and risk factors can help identify potential diagnoses and complications, guiding effective management. Today, we'll examine several life-threatening chest injuries that paramedics must recognize and manage effectively. First, let's discuss tension pneumothorax. This occurs when air enters the pleural space and becomes trapped, creating a one-way valve effect. As air builds up, the intrathoracic pressure increases, leading to a decrease in negative intrapleural pressure as the pleural space's pressure equalizes. The lung collapse, known as atelectasis, occurs due to the loss of chest wall and lung coupling. The pressure continues to increase and displace the mediastinum, asserting pressure on the heart, vasculature, and opposite lung, and may result in rare signs like tracheal deviation. Notably, as the pressure builds, the vena cava collapses, decreasing venous return and thus cardiac output. This can lead to jugular vein distension and obstructive shock, characterized by tachycardia and hypotension. During auscultation, you may notice decreased or absent lung sounds and hyperresonance over the affected area. Additional signs include respiratory distress, tachypnea, hypoxia, pain on inspiration, and unequal air entry. If air escapes into subcutaneous tissues, it may cause surgical emphysema, which produces bubbling sounds beneath the skin. In comparison, if the cause is iatrogenic, the tension pneumothorax will develop suddenly, resulting in BVM resistance and a sudden drop in SpO2 and blood pressure. Next, we have the open pneumothorax. This injury allows air to enter the pleural space through an open wound, which can lead to tension pneumothorax. Key signs include pain, hemorrhage, bubbling of blood and air, hemoptysis, and decreased breath sounds. Massive hemothorax involves the accumulation of more than 1.5 liters of blood in the pleural space due to vascular or organ damage. This condition increases intrathoracic pressure and can lead to hypovolemic shock, with symptoms such as tachycardia, hypotension, and dullness on percussion. It can also result in a tension pneumothorax. Another critical injury is aortic rupture, typically caused by high-speed deceleration causing shearing forces. This is because the aorta is relatively fixated to ligamentum arteriosum. This can result in life-threatening hypovolemic shock. Signs to watch for include hypotension, distended abdomen, altered consciousness, and weak femoral pulses. Cardiac tamponade occurs when more than 50 mL of blood accumulates in the pericardium, restricting heart pumping and reducing cardiac output. This is a form of obstructive shock and presents with muffled heart sounds, low blood pressure, and jugular vein distension, forming what is known as Beck's triad. Finally, we need to be aware of large flail segments, which cause paradoxical chest movement. This is characterized by free-floating ribs moving in the opposite direction of the chest wall during ventilation. Flail segments are strongly linked to pulmonary contusions and often results in impaired ventilation and high risk of respiratory failure. Thoracic vertebral fractures are also a concern and can be identified from bony step-offs, neurovascular deficits, and paradoxical breathing. Injury to the nerves that innervate the respiratory muscles can lead to respiratory distress and failure. Other injuries include myocardial contusion and arrhythmias, which may result in impaired inotropy, unexplained tachycardia, and cardiogenic shock. Pulmonary contusion, which may cause ventilation perfusion mismatch. Fractures. Rib fractures may impair ventilation due to splinting from pain or cause pneumothoraces. Sternum or scapula fractures suggest internal injuries given force required. Tracheobronchial and esophageal injuries. Abdominal organ damage. Diaphragm rupture, known as enterothorax, which is characterized by abdominal pain, bowel sounds on auscultation, dyspnea, and decreased breath sounds at the bases of the lungs. In managing chest trauma, especially in polytrauma cases, the primary survey is essential for effective intervention. Firstly, control catastrophic hemorrhages. 1. Airway. Begin by assessing the airway, ensuring cervical spine precautions are in place. Look for blunt or penetrating neck injuries, obstruction, or altered consciousness. Position the spontaneously breathing patient upright to enhance ventilation. If spinal cord injury or inadequate perfusion is suspected, lay the patient semi-recumbent with the head elevated 10 to 15 degrees. Early notification for MICA, HEMS, ARV, or Piper is crucial, as these patients may rapidly deteriorate, requiring advanced airway support. 2. Breathing. Administer high-flow oxygen at 15 liters per minute via a non-rebreather mask, aiming for an SpO2 of 94 to 98%. Monitor for equal chest rise and work of breathing, checking for life threats like tension pneumothorax and massive hemothorax. If tidal volume is inadequate, especially in flail segments, consider ventilatory support, targeting an EtCO2 of 30 to 35 millimeters of mercury. 3. Circulation. Establish 2 IV lines and consider fluid resuscitation if the patient is hemorrhaging or showing inadequate perfusion. Follow permissive hypotension guidelines. Maintain a systolic blood pressure of 70 to 90 millimeters of mercury for those without traumatic brain injury and above 120 millimeters of mercury for those with TBI. Start with 250 milliliters for boluses, reassessing frequently as hemorrhages can resume. 4. Disability. Assess the patient's disability by checking the Glasgow Coma Scale, pupil response, and blood glucose levels. 5. Environment and expose. Expose the patient to check for additional injuries while preventing heat loss, especially in polytrauma cases. After the primary survey, identify pneumothoraxes. For tension pneumothorax, perform needle decompression at the second intercostal space, midclavicular line. If unsuccessful, consider chest decompression at the fifth intercostal space, midaxillary line. Manage pain effectively for ventilation and apply a 3-sided occlusive dressing for open chest wounds. Lastly, maintain continuous monitoring to ensure stability and address any complications. Upon arrival at the hospital, pre-hospital support continues with oxygen, analgesia, and fluid resuscitation. Additional investigations, such as blood gases, chest X-rays, ultrasounds, and CT scans, are essential for assessing the severity of injuries. Ventilatory support may need to be intensified, which could include intubation and the placement of chest drains. Surgical interventions may be necessary, including thoracotomy and chest tubes for tension pneumothorax or massive hemothorax, as well as chest tubes for open pneumothorax. Hypovolemia will be addressed with blood products. For cases of aortic dissection, timely surgical repair is critical, while cardiac tamponade requires pericardiocentesis. Pulmonary contusions are managed through suctioning, and flail chest is treated with stabilization, positive pressure ventilation, and potentially rib fixation. As we look ahead in trauma management, several promising advancements are emerging. This includes pre-hospital freeze-dried plasma, point-of-care ultrasound, and tranexamic acid.